Thank you, sir. Let's move on to today's last case discussion. Our patient is regarding hemophagocytic lymphohistiocytosis secondary to dengue fever. A 42-year-old previously healthy woman presented with 5 days history of intermittent low-grade fever. She had fatigue for 3 weeks and fever associated with arthralgia, myalgia, and recto-orbital headache. On examination, patient was pallor, icterus, and detected her low blood pressure, and abdominal examination revealed tenohepatomegaly. She came with dengue serology report that done at day 3 of fever. Dengue NS antigen and dengue IgM antibodies both were negative, and dengue and IgG antibodies were positive. There were significant rearrangements in hematological and biochemical parameters. In full blood count shows persistent anemia, thrombocytopenia, and leukopenia with neutropenia, and the coagulation profile was normal. There's elevated transaminases, AST more than ALT, and high total bilirubin with direct hyperbilirubinemia. Total protein and albumin levels were marginally low. Patient has normal renal functions, and CRP was moderately elevated with normal procalcitonin. The etiology directed towards viral infection. The microbiology report to confirm the diagnosis, the blood culture and the urine culture were negative. The ultrasound scan abdomen revealed mild hepatomegaly, free fluid in pericholecystic and hepatorenal space, suggestive of dengue hepatitis with leaking. Patient also developed severe muscle pain on day 6 of fever, and the further investigation revealed very high serum ferritin and creatinine kinase and LDH levels. As you can see here, all levels are above the upper limit of detection of particular assay. So serial dilutions were performed to get the exact value. Despite of supportive therapy, patient continued having fever and been unwell. So we with very high ferritin and LDH with pancytopenia, we direct investigation towards HLH. Here you can see the blood picture, normocytic normochromic red cells with few polychromatic cells and moderate tular formation. RBC shows leukopenia with neutropenia, reactive lymphocytes, no abnormal cells. Platelet showed moderate thrombocytopenia, no aggregates. It was reactive film with pancytopenia. Bone marrow aspiration demonstrates increased macrophage activity, hemophagocytosis with engulfment of mainly erythroid cells. Appearance are compatible with hemophagocytic lymphohistiocytosis, which is confirmed in trephine biopsy. The similar finding. For supportive investigation for HLH, they have performed serum triglyceride levels and plasma fibrinogen. Elevated serum triglyceride level and low plasma fibrinogen levels were compatible with HLH diagnostic criteria. To find the viral etiology for HLH, perform all viral serology testing, so they all were negative. Along with severe muscle pain, patient developed hematuria of fever day 6. We have done UFR by using semi-quantitative urine temperature strip. Here you can see it's positive for blood. So positivity of blood indicate presence of RBC or hemoglobin urea or myoglobin urea. However, in urine sediment microscopy shows only 2 to 3 red cells in high power field. So myoglobin urea was a possibility with severe myalgia and very high CPK levels and absence of significant number of RBC in urine sediment. Finally, in these problems identified in this patient, dengue fever, viral hepatitis, hemophagocytic lymphohistiocytosis, and rhabdomyolysis. Uh, with appropriate management, patient was discharged after 60 days. Thank you. The discussion will be followed.
Good morning to everybody. According to that case, sometimes dengue diagnosis is very challenging and there are some problems. Also today I will discuss how to diagnose dengue with other challenges and the other problems, and also how to use the laboratory test in a cost effective manner, and what are the additional tests available for confirm the diagnosis in problematic cases. So moving on to, I'd say, two important things in dengue. Dengue is a flavivirus. So like Sri Lanka is a tropical country, we are endemic for many other flaviviruses like Japanese encephalitis, Zika, West Nile, even hepatitis C is a flavivirus. So it has a problem with the diagnosis, especially in serology. Other thing is dengue has four serotypes. Dengue 1 to 4, and one serotype infection can cause lifelong immunity, but it can cause secondary dengue if patient is infected with another serotype. So that is another diagnostic challenge. So just to understand the diagnosis of dengue, we have to see pointer. We have to see the natural history of dengue virus infection. Usually after incubation period following a mosquito bite, the virus is in the body up to 6 to 7 days. At the same time, with the virus, they will secrete this NS1 antigen. Then around day 4, day 5, IgM antibodies, that is the antibody of acute response, will appear, and this IgM can be last up to 3 to 4 months. It starts around day 4-5 and it will last for 3 to 4 months. Then the other thing is dengue IgG antibodies also appears around day 5, day 6. It will peak around day 7 to day 10 and it will persist for lifelong. So this is very important to select your test depending on the timeline. Then in dengue, it's a bit of a difference because you can get infection with another serotype. So this is primary infection. I have explained the same. Then at the secondary infection, when you infected, you already having the IgG. So from the day one, the IgG antibodies will shoot up in a large levels. So the IgM response in secondary dengue is very poor. So your diagnostic test cannot detect sometimes IgM response. And the another thing is this NS1 antigen is secreted into the blood. So in the blood, within first week, NS1 antigen and also large level of IgG antibodies, it will form the antibody antigen complex, and your laboratory test may not be able to detect this NS1 antigen in secondary dengue. So that may be the reason in our case. So there may be another reasons for that. So please remember this thing. In secondary dengue, NS1 sensitivity is less. I will discuss on that. Other thing is IgM antibodies will last for 3 to 4 months. So that also very important to understand. So in viral diagnosis, mainly for dengue is a clinical thing. But in sometimes it's very important to identify some atypical clinical presentations. Then patients with complications like this patient may be co-infections, and then the post-mortem diagnosis, because every dengue death has to be gone to a national dengue death review. So it's very important to do post-mortem diagnostic. The other thing is epidemiological and the academic interest and maybe future directions. The diagnosis might be important, not the clinical diagnosis. So for diagnosis, there are two main methods. One is this direct methods. We can do the viral isolation. We can do molecular methods like detection of viral RNA, or we can do the dengue NS1 antigen detection. And there are indirect methods. We can go for IgM antibodies and then the IgG antibodies. So when and what? So for RNA detection or NS1 detection or viral isolation, you have to take the sample for the early phase of the illness. We have to take the sample usually within first 5 days of the illness. Then if we are going for antibody testing, you have to take the sample from the late phase, usually after day 5. So if you are sending in the either way with the request form, you will get the false negative results and the waste of the reagents as well. So for RNA detection, you are using mainly by the RT-PCR. It's very highly sensitive. It's almost 99% sensitive in primary and secondary dengue with 100% specificity. It's usually recommended for first 5 days of illness but can be positive up to day 10. So this test, you have to understand, it's an expensive test. Availability is limited, so we have limited it to a complicated and problematic cases only. And we can do serotyping in this one. Another big factor with our some clinical problem is sometimes they ask for a dengue serotyping for the complicated cases, but according to up-to-date knowledge, there's no connection between dengue serotype and the virulence. So the serotyping is only required for the epidemiological purposes only, not for the diagnosis or not for the predict the complications. So moving on to NS1 antigen detection, usually it's recommended up to day 5, but can be positive up to day 10. The major problem is primary infection. The sensitivity is 90 to 95%, then it will gradually reduce, go up to day 5. But the problem is secondary dengue. The sensitivity is 40 to 70%. So if a patient is in secondary dengue, this test can be negative. So you can't rule out secondary dengue in NS1 antigen. But one clue is if you do IgG, NS1 will be negative, IgM will be negative, but IgG is positive. If you do 3 tests, if it is IgG with a clinically compatible dengue, you can suspect it's a dengue. And it's very highly specific, and there are some reports that it can cause false positive in with Zika virus infection. Even I think Dr. Sunishkar, what we got couple of years, severe sepsis, the NS1 got the false positive results for some lepto patient or something. For antibody detection, usually we recommended it after day 5. This IgM positive indicates only it's a recent infection. So if you want to confirm it, it should be a seroconversion. That IgM should be negative, then a couple of days later it should be IgM positive. Otherwise, this IgM can be last up to 3 to 4 months, I said earlier. So 1 month ago, patient can be get like very mild symptom dengue or asymptomatic dengue. Then this time comes with another infection, IgM will be positive. So we might misdiagnose as dengue. So that is a big problem because this IgM may last to 60 to 90%. So dengue IgM positive means you can't say it's confirmed dengue. So you have to think about another cause also if it is not clinically compatible. And also other thing is it strongly cross-react with other flaviviruses. So sometimes, like example, 13-month-old baby can be presented with fever, dengue IgM positive. That IgM will be due to JE vaccination in 12 months. So these serology results you should interpret very carefully with clinical and epidemiological findings. In secondary dengue infection, the IgM sensitivity is very poor. You can get the negative results. And there are, depending on the test, the sensitivity and specificity might differ. So especially in small private sector laboratories, they use this rapid testing, so it has a reduced sensitivity compared to the gold standard test like ELISA. So then IgG antibodies, same thing. strongly cross-react with other dengue flaviviruses. So it gives like a past infection or vaccination. But in secondary dengue, you can detect high IgG levels. It's a quantitative levels in early phase. So with that, you can diagnose secondary dengue also. So what we recommend is to do the combined test. Like NS1 plus IgM IgG, it can improve the sensitivity up to 90 to 93%. But the problem is the cost. We can't afford these tests. Like we have to use 2 rapid tests for this one. So that's why we are asking the day of duration of the illness. So if it is less than 5, we go for NS1. If more than 5, we can go for IgM and IgG. When in between cases, there may be a gray zone, we can do all the testing. So if you want to do the test rationally, to avoid unnecessary costing, we need the duration of the illness. So then another practical problems comes. Now this is a big problem because low sensitivity of certain commercial tests, especially used in the private sector. There are many small laboratories using non-registered rapid ICT test which gone through by the baggages to Sri Lanka. So last week actually I come across the test kit even quoted for government tender. NS1 sensitivity is 18%, 18 registered. I don't know how it happens. Then the less sensitivity of NS1 and IgM antibodies in secondary dengue. Please remember that when you are managing suspected dengue patients. This could be something else. Then other thing is technical error when handling this immunochromatographic test, especially in small laboratories. One of my student in Anuradhapura, she did the study with samples of reports from private sector laboratories. The NS1 positive, 50% of them are PCR negative. It should be other way around. So something has happened to those reports. Maybe with platelet counts, they have given it as a positive, but that's not the true positives. So that's it. Then please remember there may be antibody cross-reactivity among other flaviviruses. So this could not be a dengue. Maybe you have to think about something else. Then the persistence of IgM antibodies for dengue for 60 to 90 days. Asymptomatic infection 1 month ago, treatable infection this time. We might misdiagnose it as a dengue because of IgM. Then diagnosis of postmortem samples are very important. As previous lecture also, we have to put this into a normal saline and do it the diagnosis. Otherwise, we can't do in formaldehyde. And cost and affordability is very important because we have to do these tests very rationally. Then just I put a collection of transport specimens. NS1 for antibody detection. We prefer 3 ml of venous blood. Keep it just room temperature for 30 minutes. Can transport for the laboratory for in room temperature. If delay, you can keep it in your refrigerator. For PCR, we need a EDTA tube. You have to transport it as soon as possible into the laboratory. Then we need the duration of illness, just basic investigation results, WBC, then the clinical features, and you need what you want for this one. To confirm, to exclude, or your academic interest. So we can go for a further testing depending on our availability and depending on rationale. Because if you have a patient like this, maybe we might finish the testing on rapid test alone. So if you need to go further, we can go for a PCR, we can go for IgG quantification or anything. Right? So always please contact clinicians with us, then we can go back and do it. Because always we store the sample at least for 1 week. Like this patient, we can take that 1 week your sample has sent to NS1 and go for a PCR. Go for IgG quantification and do the thing. Other thing is sometimes for academic interest, a lot of registrars want to write case reports. Sometimes they need to confirm. So it's too late when they come after 1 month or 2 weeks later because we don't have the sample. We already discard because we can't keep it. But if you do it within 1 month, 1 week, we can take back that sample and go ahead with the further testing. The other thing is availability and cost. In Kandy, we have NS1 antigen, IgM and IgG with limited availability, and the PCR as well. And also we have the reference test also rather than the just immunochromatographic test. And also please remember, every test has cost. This IgM in our hospital we cost around 900 rupees. Private sector it goes to 3,500. Even I surprised to see that private sector it's around 4,000 for IgM and IgG. So when you are requesting, please think about the cost as well. So, and also duration of the illness is very important, otherwise we have to do both tests. And for PCR it's expensive, but we can use as a reference test. So anything, please contact us, give the proper history and what you want, so we can go for the further testing. Otherwise it will stop just immunochromatographic testing. Thank you.
Good afternoon. I hope to discuss the important points in the laboratory diagnosis of HLH. So, HLH, as we all are aware, is a life-threatening multi-system hyperinflammatory disorder which occurs due to marked increase in activated macrophages and subsequent cytokine storm. So early diagnosis can be life-saving. However, the diagnosis is difficult and challenging. Okay, so the diagnosis of HLH is based on the presence of certain diagnostic criteria. If it's primary HLH, which is the inherited form, you have to prove the presence of certain genetic mutations, which includes perforin gene mutation. If it's secondary or acquired HLH, we have 8 criteria, out of which 5 should be present to diagnose HLH. So there are 2 clinical criteria: fever more than equal or more than 38.5 centigrades for 7 days or more, and splenomegaly, which should be there for either 3 centimeter or more below the costal margin. You can confirm by actually imaging. Then we will come to the laboratory criteria. First criteria is based on the full blood count results. There should be cytopenias affecting at least 2 out of the 3 cell lines. And there are cutoffs for these cytopenias. For hemoglobin, it should be less than 9 grams per deciliter. In neonates, it should be less than 10 grams per deciliter. Platelets should be less than 100,000. And neutrophils less than 1000 or 1.0 into 10 to the power 9 per liter. So, presence of bicytopenia we have to prove. So, therefore, when we are depending on these fine criteria for diagnosis, sample collection is very important. You have to have the EDTA tube with the correct amount of anticoagulant, and there should be proper mixing with 7 to 8 times inversion, because certain analyzers
aspirate the top 1/3 of the sample. Certain analyzers aspirate the top 2/3 of the sample, not the bottom part. Therefore, if you don't mix it with this much of inversions, the cells will be at the bottom and you will get a pancytopenic report, which is factitious cytopenia. Right? So, therefore, mixing is very important, and then it should be a non-big part sample. Then the next criteria is hypertriglyceridemia and or hypofibrinogenemia. Fibrinogen level should be less than 1.5 grams per liter. Why do we have hypofibrinogenemia in HLH? Stimulated macrophages secrete cytokines. These cytokines stimulate tissue plasminogen activator, which cause increase in plasmin, and plasmin triggers fibrinolysis. This leads to low fibrinogen level. Then also cytokines activate factor 10, which initiate blood coagulation and trigger an overconsumption of fibrinogen. Then there can be liver dysfunction, because in HLH we can have multi-organ dysfunction. This causes low fibrinogen level. So when you are going for a fibrinogen level, again correct sample collection is very important. You have to use the sodium citrate tube and the correct proportion of citrate to blood, which should be 1:9. 0.2 citrate to 1.8 blood. In commercial tubes there is a mark and the collection should be right up to the mark, not below or not above. And the samples should be kept at room temperature if you are analyzing within 2 hours. Right? If you keep it more than that, you can get factitious hypofibrinogenemia. Okay. Then coming to the hypertriglyceridemia, the triglyceride level should be more than 3 millimoles per liter or more than 265 milligrams per deciliter. Why do we get high triglyceride levels in HLH? Because there is decreased lipoprotein lipase activity, which is triggered by the cytokine TNF-alpha. Therefore, there will be high triglyceride levels, and the sample collection I think will be discussed by Dr. Dulani. Then coming to the most important criteria, which is hemophagocytosis. This is present not only in the bone marrow, it's present in spleen, lymph nodes, liver and CSF, right? Bone marrow involvement may be evident in only 40% of cases that have extensive disease elsewhere. Therefore, absence of hemophagocytosis in the bone marrow does not rule out HLH. So these are some photomicrographs of hemophagocytosis. Is the pointer coming? So this is phagocytosis of erythroblasts. Then you will see phagocytosis of neutrophils, red cells, right? And the cornermost one will show phagocytosis of platelets, right? So erythroblasts, red cells, granulocytic cells and platelets all can be phagocytosed by these activated macrophages. This is a higher power view. So is bone marrow hemophagocytosis equals HLH? There can be many other conditions where you will see just hemophagocytosis. So all these cases are not HLH. You can see it in infections, inflammation, myelodysplasia, hemoglobinopathies and so on. Therefore, presence of hemophagocytosis in the marrow is not always specific. It's neither specific nor sensitive for the diagnosis of HLH in isolation, right? In isolation, it's not specific or sensitive. And there is no objective threshold for this morphological criteria. For example, this number of hemophagocytic foci in 100 oil fields or something like that is not there. No numerical cutoff. Right? So that also makes decision making difficult if you don't have the other criteria together, and if the clinical context is not meeting with the HLH. Right? This is a photomicrograph of lymph node. If you happen to do a lymph node biopsy in a patient with fever, undiagnosed fever, if there is lymphadenopathy, you happen to do a lymph node biopsy, you might see hemophagocytosis. I don't think we generally go ahead with lymph node biopsies to diagnose HLH, but you might see. So that's about hemophagocytosis. Then the next criteria is high serum ferritin. Actually, the cutoff given is more than 500 nanograms per milliliter. Serum ferritin is an acute phase protein. It is elevated to this degree or even further elevated due to various other disease conditions. Right? And usually the cases we see have ferritin levels much higher than this cutoff if it's HLH. And this is not affected by iron therapy. The ferritin level, there is a misnomer that ferritin level is affected by iron therapy. It's not affected. And sample collection will be again discussed by Dr. Dulani. Then coming to the two other criteria which we don't have facilities in Sri Lankan setup to do. One is low or absent NK cell activity, which is measured using chromium-51 release assays or flow cytometry based assays. This is very effective in detecting NK cell activity, but a cumbersome test. And the other test is soluble CD25 assay, which detect the soluble interleukin-2 receptor alpha levels in plasma. This is produced in response to the activated B and T cells. Levels more than 2400 units per milliliter is diagnostic. It meets the HLH criteria. There are immunologic assays using anti-CD25 antibody. ELISA kits are available. So this test and NK cell activity we are unable to do in our setup. So we are left with only 6 criteria to diagnose HLH, and 5 should be met to make the diagnosis. So this is making our life difficult. And the other thing is, HLH may have an insidious onset in some patients where all criteria are not always fulfilled. Patients may develop one or more criteria during the course of the illness. Initially, all 5 are not there, but after some time, certain criteria develop. For example, your first bone marrow may be negative, and if you do a second bone marrow sometime later, it may be positive for hemophagocytosis. So, all this makes the diagnosis difficult. Right? And there are some supportive evidences which will help you to go towards the diagnosis, which is one thing is CSF cytology, which will show moderate pleocytosis and elevated proteins, then elevated transaminases, bilirubin, LDH, lymphadenopathy, skin rash, coagulopathy, multi-organ dysfunction. These will support your diagnosis. Right? So because of this difficulty in diagnosis, people have developed a score to diagnose HLH, which is called H score, where you take each criteria, and for the degree of the severity of each criteria, you give a certain score. For example, if we take serum ferritin, if it's less than 2000, the score is 0. Between 2000 to 6000, the score is 35. Like that, we will give a score to the degree of severity and then add on all the scores. And if the cutoff is more than 166, you diagnose HLH. So even if bone marrow hemophagocytosis is not there, if the cutoff is more than 166, you diagnose. So this is used by certain centers, and there are softwares available online. You can put all your values, triglyceride, ferritin, blood counts, everything. You can put the values into the software, and the software will give you the score. Right? So this is all this about HLH criteria. Then a word about ESR. ESR is high in acute infection inflammation due to the presence of acute phase proteins. These proteins will expedite the erythrocyte sedimentation. Therefore, ESR is high. Fibrinogen is also an acute phase protein. In HLH, due to the reasons I mentioned before, there is a drop in fibrinogen level. Therefore, your initial ESR, which is high due to infection inflammation, will start dropping if the patient is developing HLH. Right? So for you to detect this, you need to have again correct sample collection. This is how you do ESR. There is no calculation, no chemical analysis or anything. You just mount the sample on this Westergaard tube and keep it for 1 hour. Then the erythrocytes sediment, and you measure the height of the column. So you can have two types of samples for ESR, either EDTA sample or citrate sample. Your EDTA sample, you can be subsequently dilute it with trisodium citrate, 1 volume of citrate to 4 volumes of blood. That means 0.4 ml citrate and 1.6 ml blood. This correct proportion must be maintained, otherwise you will get a wrong ESR. Right? And the samples need to reach the lab, and test should be done within 4 hours of collection ideally. If there is a delay, you can keep the citrate diluted sample for 6 hours at 4 centigrades. You can keep the EDTA sample up to 24 hours at 4 centigrades, and immediately before testing you can dilute with citrate. Okay. So this is about ESR and sample collection. The take home message is, when your diagnosis is based on certain criteria, the sample collection is extremely important, because you might get factitious cytopenias, factitious hypofibrogenemias, and you might take false positive or negative criteria, and you might go for misdiagnosis. Okay, thank you very much.
So we have come towards the end of the symposium. I will be discussing the chemical pathology aspect. Basically, in this patient, there were a lot of biochemical investigation was done. So I will discuss some important points that you should know during the sample collection and the transport and the interpretation. The first one is the ferritin. As the Dr. Vishaka described, ferritin is the test that will assess the iron stores, and for that we need a sample of blood we assess it in the serum. So we recommend collect the blood for the plain tube, and no need of fasting. Sometimes people ask whether there is need of fasting, and you can collect even the patient is on iron therapy, you can collect the sample for ferritin. And if you are sending it away, that if the ferritin is not done in the center that you are working, you have to separate the serum and send it away. And if you refrigerate also, you can't keep the sample in the vault. You have to send the sample after collection to the laboratory and separate the serum. That serum can be stored for further analysis. And is the ferritin is the storage form of iron, and it can be used as a biomarker of iron stores, and it also for the assessment of iron deficiency and iron overload we use it. And special note, as explained earlier, it's the positive acute phase reaction. So if you assessing the ferritin in the acute phase of the patient, if the CRP is high, patient is in acute infection, you might not it can mask the iron deficiency. So interpretation must be done cautiously. And in the HLH, due to the acute severe inflammation, you can get hyperkalemia as explained earlier. The assay method, we done it by the immunological method. So there we have the antigen antibody reaction we use for the detection, and we catch the ferritin molecule with using the antibodies. So different analyzers in different laboratories might have different antibodies for the detection. So this can cause variation in the results from platform to platform in the various laboratories. So that's why there are possible results of discrepancy. Sometimes clinicians ask why in the same patient done in this laboratory and this analyzer there is one result and other one same sample different results. This could happen due to the analytical variation because we use antibodies and different platforms use different antibodies for the ferritin molecules. So the interpretation better to do with caution and better to do follow up in the same laboratory or the same analyzer for the follow up of the patient. And if it is very high, usually in the biochemistry, the test methods have been developed for the detection of certain limits. But in the abnormal condition, in pathological conditions in the patient, the values might be very high. So these are the biochemical methods. So we do the chemistry. So to get that value to the linearity limit of detection, we might have to do previous, that is before the analysis, dilution steps. To do that, we need the information from the clinician. What is the patient clinical condition? What is the previous value? So straight away we can go for the dilutions. Otherwise, we might not do the dilution and give the results. And when you see the results, then we have to go back, get another sample and do the dilution. So that information is important. Then the LDH. So LDH was high in this patient, HLH. And it's an enzyme. It's present in many cells in the body, found in cytoplasm of the cells, and cell lysis or the proliferation due to malignancy can cause elevation of LDH. Earlier it was used as a marker for myocardial infarction, but there are more novel markers for myocardial infarction, so no longer use it. And it is useful for the detection of effusion, whether it is exudate or transudate. For that, we have to couple the pleural fluid aspirate with the serum sample and get the value and apply the Light's criteria for the interpretation. And it has several isoenzymes, but in laboratory, we can't differentiate it with our available method. We use the all isotopes together, the total amount of LDH. So we can't differentiate whether it is coming from skeletal muscle or liver. We can say it is high. And in the HLH or the rhabdomyolysis can cause very high level of LDH. And again LDH assay, we want the serum and we measure the total LDH activity because it's an enzyme, and the sample serum is preferred, and because if you get plasma it may contain platelet and it can cause false elevation. For the more accurate values, we have to separate serum from the cells as soon as possible. If the sample is hemolyzed, you can see that RBC contain very high concentrated LDH. It will release into the serum and you get false high values for the report. And LDH4 and LDH5 are code labeled. So if you store the sample in the refrigerator before analysis, it can cause destruction of these isoenzymes and cause false decrease of LDH values. So what is recommended that you have to collect the sample, analysis should be done on the same day. That's why we recommend usually send the sample and we are done it as a batch analysis on the recommended dates. And for the triglyceride, that's triglyceride we commonly use as part of the lipid profile because it's the type of lipoprotein. And triglyceride, if we in the fed state after meals, it's mainly from the chylomicron. If it is in the fasting state, it is from the VLDL. So that's why for the interpretation purpose, we recommend patients to be fast. 12 to 14 hours fasting recommend to eliminate the chylomicron. Assume that chylomicron is not there in that sample. So we assume that triglyceride we measured is from the VLDL. And it is catalyzed by the lipoprotein lipase and free fatty acid will release and taken up by the cells. And the pathological mechanism for the increase of triglyceride levels in different pathological condition, diabetes mellitus, HLH, it is due to the diminished activity of the lipoprotein lipase, and in the alcoholics it is due to increased hepatic production of VLDL. And certain condition there can be a combination of both conditions. So clinically for the sample collection, traditionally we recommend for the sample collection 12 to 14 hours fasting, and but we can collect without fasting triglyceride. Non-fasting sample, it will measure all possible triglyceride that it will reflect the patient usual metabolic state. And so it's the acceptable alternative, but we have to use appropriate cutoffs and interpretation guidelines for the non-fasting sample. So it's not yet adapted for the clinical practice in routine clinical practice. Then the liver enzymes, very commonly used test ALT and AST. Most of the patients, most of the infections, most of the condition we have to assess the liver status. We do the ALT and AST together, and the ALT is commonly in the cytoplasm of the hepatocytes and AST found in the cytoplasm and the mitochondria both. So increased activity, because these are the enzymes we measure the activity in the serum. Increased activity will indicate disease processes affect the liver. Cell integrity. Cell must have been damaged and these enzymes must have released into the blood to increase the activity in the serum. And out of that, ALT is more specific for the hepatic injury and AST is not specific because it can be released from damage to the myocyte, skeletal muscle and red cells. And why we do these together? Because the ratio for the hepatologist, it's very important that the ratio, even ALT and AST within the reference ranges normal mean, if the ratio is reversed, it could be pathological. So it's important to have a look into the ratio of the ALT and AST. So it's done by the enzyme assay. Again, in the condition where there can be a very high levels like viral hepatitis, paracetamol poisoning, you can have very high levels of ALT and AST. So in this situation, in the laboratory, we need to have higher dilution steps. Some analyzers have automated, they can detect there is a high limit and they will do automated dilutions. But some analyzers, they will not. So if it is not done, it can cause false negative results in the report. So the previous values and the clinical history is important for the laboratory to get an idea whether this sample should be done with the dilution. So the communication with the laboratory technicians, doctors in the laboratory to do the certain steps without any delay to get the results on time accurately is very important. Then the other test that was done in this patient was CK, creatine kinase. It's an enzyme found in skeletal muscles, heart muscles and brain. It also has isoenzymes, but we can't differentiate. We measure the total CK activity. It will increase in the injury, inflammation, necrosis in the skeletal muscle or heart muscles. And the rhabdomyolysis is the commonest condition that will cause very high elevation of CK activity. It can change with the muscle mass, physical activity, and the age and sex. And the test, again, the test method for the high values, we need dilution, and the clinical history and the information important for the timely results. Then the other test that was done for the rhabdomyolysis is the myoglobin in urine. So myoglobin, what is myoglobin? It's iron containing heme protein, mainly found in the skeletal and cardiac muscles. And following the muscle injury, it will be released into the blood and it will be filtered by the glomeruli and appear in the urine. And it will cause dark color in the urine. And it is toxic to the renal tubular cells. It causes damage to the renal tubular cells and can cause renal tubular necrosis and renal failure. So this is the appearance of the patient's sample urine, dark color urine. So if you suspect myoglobinuria or the hematuria in the patient, usually you request UFR or the urine dipstick test. So it's a qualitative test, and when you do it, if it is hematuria or myoglobinuria, you will get a positive for blood. But we have to differentiate the hematuria or the hemoglobinuria, whether it is myoglobinuria. For that, we have to go for the other evidence like the CK elevation for the evidence for rhabdomyolysis and the sediment examination, presence of intact RBC. Those are important. So this is the appearance that we will get in this strip. So this has several strips that tested, and with the indicators you have to check which are positive for which test. So this is a point of care test because several tests can be done by a single strip and you can get more information from this test. But the sample collection and properly done test is very important. Proper procedure should be followed. This is the how it appears for the dipstick. It is given in the indicators. Either hematuria, hemoglobinuria, or myoglobinuria can cause positivity. And from the dipstick interpretation, we can say whether it is intact cells or hemolyzed. So this information also we can get from the dipstick test. So the proper procedure and interpretation is important. This happens because the reagent that we use, that impregnated in the strip, is react both with hemoglobin and the myoglobin. And finally, the take-home message is out of all these symposium, what we want is we want for the laboratory, for the clinicians in the laboratory, doctors in the laboratory, we want the information because what we get is a sample. It may be blood, it may be urine, or the sample or biopsy together with the piece of paper about patient history. So from that we will imagine a patient and we have to do certain steps and give interpretation and conclusion. That's why we want communication and share, and together as a team we might have get with available resources in the situation of the country. With available resources we might have to give better outcome for the clinicians and the surgeons to do better patient management. Thank you. We can get any questions for this case.
If you have any questions, it's time to ask. The question is to Dr. Vishaka. You said the ESR falls in HLH. What are we looking at the ESR? Can you say how fast is it, a very minor thing, or is it significantly fall, or can it be used as a marker?
Depending on the degree of fibrinogen drop, you can see a significant ESR drop in certain patients, not all the patients. It always depends on the degree of hypofibrolemia and how fast it develops.